The following episode is brought to you by the American Urological Association. This episode features content from the AUA 2026 meeting in Washington, D.C. For more information on how to claim CME credit for your participation or to view faculty disclosures, please visit the AUA University. Support for this activity has been provided by independent educational grants from Astellas, Lantheus Medical Imaging, Novartis Pharmaceuticals Corporation, and Pfizer Inc.
Well, good morning, everyone. Thank you for getting up early and making it to this course. There's a couple of housekeeping items we have to go through, and then we'll get started. The AUA has asked that I read these statements, so the AUA 2026 annual meeting mobile app is available and free to download. When you download the app, you'll be asked to use a username and password. Thank you to the supporters. The American Urological Association would like to thank the following companies for providing independent educational grants in support of the educational series: Astellas, Lantheus, Novartis, and Pfizer. Course materials are available on the AUA 2026 website and mobile app. Use the email that you use to register. Your password is your AUA ID. You can find it on your registration badge. General welcome and instructions. As part of the disclosure policy, the AUA determines whether disclosed relationships with ACCME defined ineligible companies are relevant to the educational content of the CME session and mitigates any conflicts of interest prior to the session. The full disclosure policy and report of relevant financial relationships are posted on the AUA annual meeting's website, aua.org/annual meeting, and a link is posted in the mobile app. CME credit claim, please ensure that you log into the CME credit claim site and confirm this session has been added to your record. The link is posted in the mobile app and through QR codes in the meeting guide and signage. Please follow the instructions on the site to ensure that you're complete an entire credit claim process for all the sessions as soon as possible and no later than December 31st, so end of the year. No credit will be available after this time. Please remember to silence your cell phones, and no photos, video, or auto recordings are permitted. So with that in mind, we'll get started. Again, if you're in the right place, this is the Should I Order a PET Scan Integrating Molecular Imaging into Urologic Oncology Clinical Practice, Current Approaches and Future Opportunities. We do have to push a little bit on this to get it to move forward, huh? Maybe I'll try this other one. There we go. Course objectives are here. I won't read them out to you, but essentially we'll be covering molecular imaging in terms of PET scans in 4 different urologic oncology malignancies. Often this is the algorithm that has been historically provided and how we stage different cancers. You can see typically local imaging, distant imaging, and bone scans have been used for initial staging, and really molecular imaging has been relegated to those patients that had equivocal findings on alternative imaging staging. Really, kind of this course will talk about, can we replace this initial step with moving straight to molecular imaging in terms of staging, as well as looking at some treatment response. So with that in mind, I'll briefly introduce our faculty. Dr. Michael Gorin from Mount Sinai will be discussing kidney masses and the use of molecular imaging for kidney cancers. Next, Dr. Spencer Baer from University of California, San Francisco, nuclear medicine physician, will be talking about PSMA PET imaging and prostate cancer. That will be followed by Dr. Tracy Rose from the University of North Carolina, Chapel Hill, medical oncologist. They'll be touching base on testis cancer and molecular imaging. And then myself, Mark Bierland, also from the University of North Carolina, will be discussing bladder. With that, I'll turn it over to Mike to get started on kidney.
Thank you, Mark. Thank you, as always, for organizing this course on behalf of the AUA and for the invitation to attend. It's always one of the highlights of my meeting. How many years have we been doing this now, Mark?
It's got to be, I don't know.
6, 7 years?
Yeah,
that's great. And to think when we first started, like PSMA PET wasn't even FDA approved, and now it's like, it's incredible. I'm going to be talking about the histologic characterization of the indeterminate renal mass with the use of molecular imaging. Realize that there's a whole nother world of molecular imaging when it comes to kidney cancer, just for advanced stage disease. That has a much less defined role, or much less, I would say, of a clinical need than does the small renal mass, and that's because largely with conventional imaging, we could see metastatic kidney cancer quite well. And if you want to learn more about that topic, you could go to my YouTube page. I have a lecture on there with respect to that. So disclosures relevant to this talk. I am a co-inventor with my research partner, Dr. Steve Rowe, on a number of small molecules targeting CA9, but none of them are really at the commercial phase yet. I think everyone in the audience is aware that there's been a tremendous increase in the incidence of the indeterminate small renal mass, and this is simply because we now rely on cross-sectional imaging, whether it's CAT scan, MRI, and ultrasound, for virtually all we do in medicine, and so there's just so much more opportunity now to pick these things up incidentally. But it's important to realize that not all renal masses are necessarily cancer, and if they are a cancer, they're not necessarily of a histologic subtype that's necessarily immediately life-threatening. So these are the most common histologies. Clear cell renal cell carcinoma representing the majority of small renal masses, roughly about 75%. And then we have the oncocytoma, which is a benign renal mass representing anywhere from 10 to 20% of all indeterminate tumors. So on the opposite end of the spectrum, they're going from perhaps the most aggressive to one that is completely benign. And what we know is that depending on the histology of the underlying histology, the prognosis for patients, again, is quite different. We have the benign ones, which pose no threat to life or limb whatsoever, I guess with the exception of an AML, which could potentially bleed. And then among the RCC subtypes, we have ones that you could even not treat and just watch, and patients do pretty well, to ones like, if it has a sarcomatoid element to it, could be very significant and life-threatening for patients. So these are the most current guidelines from the NCCN, and you can see we have a myriad of treatment options available to patients who present with a clinical T1A or clinical T1B renal mass, and that's because of the biology of these tumors until they're classified is quite varied. And you can see it ranges all the way from radical nephrectomy to percutaneous ablation. Now we have SBRT and surveillance and so forth. And so to help us be able to differentiate between these entities when we have an indeterminate mass on imaging, the guidelines talk about the role of biopsy, and then once you know the histology and the relative aggressiveness of it, you could then choose between one of the different treatment approaches or surveillance and so forth. But there are significant limitations to renal mass biopsy. It's associated with patient pain and discomfort and lost productivity. No one wants to miss a day of work, especially with the rising cost of living these days. And there's a not insignificant non-diagnostic rate. Boy, that's a lot of negatives in one sense. There's a significant non-diagnostic rate, and it's estimated to be anywhere between 10 to 20%. And this number doesn't even take into account the number of masses that we don't biopsy simply because they're in a location in the kidney where if we were to biopsy it, we have a high risk of morbidity associated with that. For instance, if it's like tucked up behind the liver or something like that. So the non-diagnostic rate is 10 to 20% of all those where we even attempted a procedure, but there's probably a significant number too where we just can't even biopsy it. The major complication rate is roughly 1%, and even when we do hit these tumors, we're unable to accurately determine grade, and then we have this thing called the oncocytic neoplasm conundrum, where a bunch of different tumors look kind of similar underneath the microscope, and it ranges all the way from type 2 papillary, which is a more aggressive histologic subtype, to oncocytoma again, which is benign. And so if all you have are these pink cells from a little tiny tissue core underneath the microscope, you could still potentially get the diagnosis wrong for patients by a lot, actually. So the question then becomes, can we use molecular imaging to help differentiate between the various renal tumor histologies? And of course, the answer to that is we can, otherwise I wouldn't be giving a talk today. And there are really sort of two molecular imaging tools that I'm going to talk about. One of them is a PET scan, and it's uses a molecule called girentuximab, which is a humanized monoclonal antibody against carbonic anhydrase 9. And that's for helping to detect clear cell RCC. Not quite FDA approved yet, but it will be hopefully quite soon. And then we have sestamib, which is not a PET radiotracer, but a SPECT radiotracer, but still a molecular imaging agent. And that is readily available to us, although the level of evidence for it is quite a bit weaker than girentuximab. So I'm going to run you through sort of the rationale and how you use both of these imaging techniques. So let's just start kind of with carbonic anhydrase 9. So I think most in the room are aware that one of the pathognomonic features of clear cell RCC is that in virtually all cases there's loss of the von Hippel-Lindau gene. And the VHL gene is responsible for preventing HIF-1 alpha from translocating to the nucleus, where then it upregulates VEGF production as well as CA9. And what carbonic anhydrase 9 usually does is in hypoxic environments, it buffers the microenvironment. So when you lose VHL, you get basically constituent activation of CA9, so it ends up being a good cell surface marker for differentiating clear cell RCC from other histologic types. So here you could see the H&E on the left and then the immunohistochemistry on the right, and you could see that clear cell RCC is just jam-packed with the CA9 molecules that you could readily detect, whereas papillary RCC doesn't express it at all. And so folks have taken advantage of this through the development of the girentuximab antibody, and if you label it with a radionuclide, you then have the ability to be able to detect clear cell RCC apart from other renal tumors. Not the earliest report, but probably one of the most substantial early reports on this concept came about in 2013. It was published in the Journal of Clinical Oncology. It was called the REDECT trial, a basic image and resect trial where patients with an indeterminate renal mass underwent imaging with girentuximab PET. At the time, they were using I-124 as their radionuclide. Then they would undergo partial radical nephrectomy, which then served as the reference standard to compare the PET results to. It was also compared to just simply the radiologist's suspicion of what the tumor histology was on the basis of contrast-enhanced CT. And what they found was that you basically yielded a 10% improvement in the sensitivity for detecting clear cell RCC, but the biggest gains were made in terms of specificity, which translated then to accuracy number of 86% versus only 68%. And so this really got the field then interested in pushing this concept forward. Unfortunately, though, there were some issues with the intellectual property and the company at the time who was behind that compound going out of business. But lo and behold, Tilex Pharmaceuticals, who you may be familiar with already, as they make one of the kits for producing gallium-68 PSMA-11, they went ahead and picked up this IP. They did some science, some basic science work and re-engineering of the antibody. They replaced I-124 with zirconium-89, and then moved forward with a phase 3 trial, which I'll show you the results of now. So first, why zirconium-89 as opposed to the I-124 labeled antibody? Well, it has to do with the fact that you get what's called charge trapping, so that zirconium-89 radionuclide, once it's bound to girentuximab and gets internalized, because of the charge differential, you get more accumulation of the antibody in the cells, and so you get a much better signal-to-noise ratio. And so the thought being that while we had very good results in the REDECT trial, perhaps they could be even better once this molecule was re-engineered. And so we had the Zircon trial, which was published 2 years ago now in Lancet Oncology, a similar image and resect design, and it essentially was able to replicate the results of the earlier REDECT trial, showing a sensitivity and specificity of 84% for being able to detect clear cell RCC apart from other renal tumor histologies. There are, though, some limitations of girentuximab PET, which I think are noteworthy, and that is that it's an antibody-based radiotracer with a long circulating time. So the other radiotracers that you're going to hear about for testis and prostate and bladder imaging. These are F18, largely F18 or gallium-68 labeled radio tracers, where essentially you inject it in the patient, then an hour later you put them on the scanner and you get really beautiful images. The antibody, because it's not a small molecule, it takes a really long time for it to bind to its target and internalize. So with girentuximab or immunopet in general, you usually give the radio tracer and then wait a few days before you put the patient on the scanner. And, that's potentially problematic when you have a patient traveling from a far distance, right? You have to have them come, you give them the antibody, then they, drive back home and then have to come back again 3 days later. It just sort of creates workflow issues. There is a high cost of PET in general, and I put that statement in there to contrast it with SPECT CT, which is, probably an order of magnitude less expensive than PET CT, and we'll be getting to SPECT CT in a moment with Sestamibi. There is limited availability with PET in certain parts of the world. It is also limited by the distribution network because it is an antibody that's labeled with zirconium-89. It requires very specialized manufacturing and radiochemistry production facilities, and so then because the radionuclide burns out in time, you have to be near enough to one of the sites that could produce it to be able to receive it, to give it to patients. So it's not the sort of thing which you could plant and use in every corner on Earth. And it's very expensive. Once it's approved, it's going to be on patent for a lot of years, and so you could expect this radio tracer to be thousands of dollars to use for patients. And again, I put that point in there to draw the contradistinction to Sestamibi, which we'll talk about in a few moments, which is like pennies compared to an immunopet agent. But probably the most sort of medically and scientifically important limitation here is that it only tells you clear cell RCC apart from other histologies. And that other histologies category includes both benign and malignant renal masses. So you could have, say, like a chromophobe RCC with a sarcomatoid component, one which is like very, very dangerous, and it's going to be cold on girentuximab PET. So knowing that it's a clear cell doesn't really tell you what to do clinically with that patient. And yes, I acknowledge that those other tumor histologies that fall into the cold category that are potentially dangerous are few and far between. But at the end of the day, what we're trying to do here is figure out who I could get away with active surveillance versus who needs a partial radical nephrectomy. And I am a bit limited in my ability to do that. So in the end, for those negative scans, you still have to consider potentially doing a renal mass biopsy. But then again, benefit being that you get to avoid a biopsy in all those patients with a hot scan. So going back to my original question, can we use molecular imaging to differentiate among the various renal tumor histologies? Of course we can, but is there also a way to do this by addressing some of the issues with girentuximab PET? And this was sort of a journey then that myself and my research partner Steve Rowe went on about 10 years ago, sort of to identify that molecule and develop a scientific foundation for translating this into clinical practice. So I had learned from Steve, who's a nuclear medicine physician radiologist, about Sestamibi. Sestamibi is a lipophilic cationic molecule that's used in everyday clinical practice for doing cardiac scans. The way the molecule works is because it's lipophilic, it diffuses across the cell membrane. It then further diffuses into the mitochondrium, where there's this tremendous charge potential, where it then gets trapped, and because of the presence of the technetium-99, you could then image it with single photon imaging. Interestingly, Sestamibi is kicked out of cells by the MDR pumps, the multi-drug resistance pumps. And so we really got to thinking here is that some of the RCCs, not only are they devoid in mitochondria, but some of them have these MDR pumps. So on the basis of sort of differences in mitochondrial content and differences in MDR pump expression, perhaps we could then use it to differentiate between the different renal masses, and I'll show you how that comes together. So I talked about it for cardiac imaging, but it's also quite commonly used for imaging parathyroid adenomas. That's because parathyroid adenomas have a cell as part of their structure called the oxyphilic cell, which contains abundant mitochondria, so it makes it so that you could easily view those cells. So it turns out that oncocytomas, the benign renal mass, one of its histologic features is it too has an abundance of mitochondria. It also turns out that it doesn't really express MDR pumps. So we got to thinking that perhaps then we could image oncocytomas with Sestamibi, and we knew that we were potentially onto something because clear cell RCC, one of its defining features under the microscope is it's devoid of mitochondria and it expresses MDR. So there was an opportunity there. It turns out there were some folks ahead of us who had the exact same idea, but unfortunately didn't run with it the way that we did. This paper was published in 1996, and it's the first demonstration of the use of Sestamibi SPECT for imaging renal masses. In this study, they only had 6 tumors, one of them being an oncocytoma, and what they found is that oncocytoma took up the radiotracer where the other renal tumor types did not, and it formed the sort of the basis for this concept may actually pan out. The problem, though, is at the time at which they did the study in 1996, they were dealing with planar scintigraphy. You could think of that as kind of like, by analogy, a planar scintigraphy is to SPECT CT as an X-ray is to a contrast-enhanced CAT scan. They're basically like Rorschach drawings, and it's very hard to use them clinically. But back in 2015, when we first started this work, we had SPECT CT available to us, and it was sort of making sense. So we did some initial pilot studies and then arrived at this phase 2 trial design, which we published in European Urology, where we had 50 tumors and we did an image and resect study. And included in that cohort were 8 patients with oncocytomas, and we found a sensitivity of 87.5% and specificity of 95% for detecting oncocytomas apart from the other renal tumor histologies. And you could see here on this slide, basically, it's not functioning as a pointer. You can see here on this slide that the oncocytoma takes up the radiotracer, whereas the clear cell RCC does not. So others have replicated our work, and here's from a review article in 2024, sort of like the world experience of papers that are out there. And while we don't have, zircon trial level data for Sestamibi, we do at least have a number of single institution sort of replication studies that are out there. And with an increasing number of tumors that we've imaged with Sestamibi SPECT-CT, we now have an evolved understanding of things, and that is that it's not only about the oncocytoma. It turns out that this entity called the low-grade oncocytic renal tumor, which is in the most recent WHO classification for renal tumors, also takes up Sestamibi, as does the eosinophilic variant of chromophobe RCC, and so does some AMLs. What's nice, though, is that all of these tumors, even though 2 of them are malignant, all of them have a very indolent course. And so you could effectively manage the low-grade oncocytic renal tumor or even the chromophobe RCC as if they were benign masses. And so binning them into the same category along with oncocytoma doesn't really pose a problem the same way that when you're imaging with girentuximab, binning an oncocytoma with a type 2 papillary is a problem. So we know that clear cell RCC, papillary RCC, and these newly molecularly defined RCCs, which are also part of the new WHO classification, none of them seem to really take up Sestamibi with any degree of importance. We recently published in the Journal of Urology our combined experience from imaging 361 renal tumors using Sestamibi. These results are combined from that first trial we published in European Urology, a second confirmatory trial that we did with 74 additional tumors, and then 237 scans that we did in clinical practice and had an open registry for. And what we do here in this table is we present the data not only by oncocytoma alone, but by adding in all the various other tumor types that we've now come to understand can take up Sestamibi. And the long short of it is that we have found a sensitivity overall of 76%, a specificity of 87%, and most importantly, because the incidence of these tumors is only in the range of 10 to 20%, given that low prevalence, when you compute the negative predictive value of this test for ruling out a malignant tumor, potentially aggressive malignant tumor, it's in 90% or more. In our study, we actually found a negative predictive value of 97% if you impute a 10% prevalence, and it only goes down to 94% if you impute a 20% prevalence. So pretty good looking performance characteristics there. And this is completely in line with what others have shown going back to that review article. So from a cost-benefit standpoint, we've done the financial analysis where we said, well, if you go ahead and perform just a biopsy on all patients with a small renal mass, what does that translate to in terms of cost? What if you just do sestamibi alone, or what if you employ the two together? And what we have found is that you could significantly reduce the cost of caring for patients who present with a small renal mass if you don't just take everyone to partial nephrectomy, but you employ one of these approaches where you first risk stratify them. And in doing this, what we have found is that you really don't miss many malignant tumors at all. In fact, if you employ sestamibi plus biopsy, the miss rate is only 0.2%, whereas you're able to correctly classify 84% of all benign tumors and avoid them from going to surgery. So in conclusion, the indeterminate small renal mass is a diverse clinical entity that includes a number of benign and malignant tumor histologies. Patients presenting with an indeterminate renal mass should ideally be managed with a risk-adapted approach, whether that means biopsy or now molecular imaging. Biopsy, while it can aid in determining the histology, there are the problems that I spoke about earlier, and molecular imaging offers the promise of a non-invasive means of achieving the same ends. Sestamibi, which is good for identifying oncocytoma and oncocytic renal neoplasms, is a very inexpensive and readily available test to aid in risk stratification. It's already FDA approved for all those other clinical indications, and it's very, very cheap. Alternatively, we have the girentuximab PET-CT, which has a much higher evidence base, having been put through a multi-center, phase 3 clinical trial, but it's not yet FDA approved, and there is the limitation of the tumor binning that I had mentioned earlier. But I do think we're going to see it take off in clinical practice, and I think that's going to be good for patients. So with that, I'd like to say thank you. Thank you again to Mark and to my co-speakers, co-presenters, and to the AUA for continuing to put this course on every year. And because I have to run to another session, Mark, am I correct? We'll do like maybe 1 or 2 questions for leave.
Happy to take questions on this topic if there is any from the audience. Yeah, if you could speak in the microphone.
Good morning. This is Álvaro Gómez Ferrer from Valencia, Spain. Is there any precaution or any limitation when dealing with patients with renal function impairment using these isotopes?
Yeah, very good question. I can't really speak to girentuximab. It's probably not cleared in the kidney. Sestamibi, though, is, and we have actually published papers just looking on the impact of renal function, and it appears not to really impact things, and you could still get pretty similar results even in patients with chronic kidney disease.
Do you routinely incorporate, or how do you incorporate sestamibi kind of into your workflow when you see a new patient with a small renal mass?
Yeah, if any patient who I see in my practice who has a small renal mass, I start with a sestamibi scan. If it's hot, then we have a discussion about active surveillance, or if they're really nervous about it, an ablative approach. If the mass is cold, however, then I move to biopsy. And if on biopsy it shows to just be a falsely negative sestamibi scan, then we're back to the discussion about surveillance or ablation. But if it's one of the other histologies, then I'm referring them to one of my partners who does partial or radical nephrectomy.
Any pushback from insurance on coverage?
No, surprisingly not. Radiology has really figured out billing in a way that urology hasn't. There simply is a code called nuclear medicine or nuclear tumor localization. It's like a very generic code, and it's doing it with SPECT, and it reimburses $300. The radio tracer costs $80. I think the scanner time is costs the hospital $100. So because it's so inexpensive, I don't think anyone cares, and the billing code is already readily available for it. I see Spencer nodding his head. That's all correct?
Yeah, that's how we implemented it at UCSF. We just started doing it under that CPT code, and it just went right on through. It was sort of surprising. We're like, we'll try a couple, and it just got approved.
Yeah, all 237 of those clinical scans, they were billed to insurance, and I never had to have a discussion with a single payer.
I'm guessing, too. It's a cost, too. Yeah, I totally think.
Yeah, it's just not worth their time.
Yep.
Well,
Wonderful.
thank you again.
All righty. Well, thank you, Mike, and thank you for all being here this morning, and thank you to the AUA for inviting us to speak. Again, my name is Spencer Bear. I'm a molecular imaging physician at the UCSF, and I'm going to talk to you a little about PSMA and prostate cancer. Let's see which one will work. There it goes. First off, my disclosures. So goals. Review the clinical indications of PSMA PET imaging. I'm going to show you various cases along the way and discuss potential pitfalls, at least from my experience of reading it from day to day and how I manage these. And then lastly, I'm going to wrap up with briefly just highlighting the role of PSMA therapy in systemic therapies. I love this schematic because it shows all the different various targets that have been done for prostate cancer PET. So as a molecular imager, the one that we use for years and years and still the workhorse for me is FDG. But we found very early on it's not really great for prostate cancer. The story really started with prostate cancer PET tracers with this one. This came out of the Mayo Group back, approved in 2012. I remember this very well because of the fact I was in the reading room when this got FDA approved, and my radiation oncologist chief called me up asking for these to be done the next day on a few of his patients. So it really gave me, I was a fellow at the time, and sort of pulled the curtain back and gave me how much need and drive there was for this. The story didn't stop with choline. They came on to the next molecule called FACBC, or oxymin. That's the amino acid-based imaging. And now, 5 years after that, the one that's really knocked them all to the side, has taken over and sort of transformed the market, is PSMA. What is PSMA? Well, it stands for prostate-specific membrane antigen. We'll sort of allude why that S is not really too accurate. It's a transmembrane glycoprotein that is massively upregulated on epithelial cells. There are 3 agents that are FDA approved. In the eyes of the FDA and the NCCN, they're all treated equally, even though when you image them, they all are a little bit different. There's the gallium-based agent and the 2 F18-based agents. And unlike choline and FACBC, which came before that, this one's got a therapeutic analog. So we can kick off the positron imaging radionucleotide and put on a therapeutic beta emitter. We'll talk about that towards the end. So how does it compare? Not going to spend too much time on this because of this. So this was the agent comparing PSMA to F18 choline. This was in a lower PSA, but clearly, look at the arrows, much higher on the PSMA versus choline, so clearly PSMA was much better than choline. What about FACBC or fluciclovine versus PSMA? Much wider range of PSMA. The reason I show this whole schematic is because it looked at different locations, looking at local recurrence versus the nodal versus osseous mets. And the local recurrence, this is the one where FACBC outperformed PSMA. Why is this? Why did they probably come across this? I think there's 2 real factors here. First off, PSMA, you see a lot of urine excretion, you see bladder uptake, and FACBC you don't. It's acquired 4 minutes after acquisition, hasn't really had time to go to excretion. The other thing is, this paper was published back in 2019. Our technology has significantly changed over those past 7 years, and if we repeat that examination, I think this data would be a lot different. But overall, PSMA outperformed FACBC. So why was there all this push for PET molecular agents? I want to call back to what we used to have. This is when I was a fellow in abdominal imaging and nuclear medicine. This is what we have to do when we're looking for staging of patients with prostate cancer and biochemical recurrence and metastatic disease. We have to wait for that PSA level to rise to about 20 to get a high positivity rate. Well, along comes choline. That floor really dropped out to a 20th of it. And then as the story continued with FACBC and PSMA, that number continued pushing down from 0.8 now to, I've seen cases with 0.05 PSA level with positive PSMA scans. How do we prep these patients? We just basically ask them to drink some fluid before the examination. Great thing about that, unlike the other one that we do day in and day out, is FDG, where we have to have these patients fast for 4 to 6 hours. So our nuclear medicine technologists are going up to them. Did you have anything to eat? Did you put anything in your coffee? What is that in your mouth? Is that sugar-free? The other thing is we don't have to worry about them. We can ask them to take all their medications. Only thing we ask them to do is go to the bathroom before they get onto the thing to get rid of some of that uptake in the urinary bladder. Normal biodistribution, especially with the gallium agent. This is one of the gallium PSMA 11. Lacrimal and salivary glands, implications with our therapies with developing dry mouth, liver, spleen, bowel, and then we have to fight the collecting system when we're looking for local recurrence and staging in the retroperitoneal and pelvic lymphadenopathy. So moving on to the current clinical indications of PSMA PET, I'm going to start off with initial staging, then move on to biochemical recurrent disease and systemic therapies. So first off, the initial staging. By NCCN guidelines, PSMA PET is indicated for patients with unfavorable intermediate, high risk, or very high risk patients. Most of our patients, in fact, all of our patients get a multiparametric MR. We get it for T-staging, accurate local assessment, including looking for extra prostatic extension. In addition, it gives us the ability to get targets for biopsy. PSMA PET is exceptionally helpful for the improvement of nodal and metastatic disease. At about 1 in 5 patients will detect N1 disease that if you'd gone to CT, bone scan, or MRI, they would have otherwise been missed. In addition, as a molecular imager and abdominal imager, so I'm reading those multiparametric MRs, it really helps us in determining, looking for that primary, not only from moving off that hedgy PIRADS 3 lesion where it's like, it could be cancer, it could be not, whether we want to biopsy it, helps us make us be more confident. On top of that, it'll detect occult lesions. That brings us up to that patient's PSMA in active surveillance. So this is not currently recommended by NCCN guidelines, but I think this is going to come down the pipes in a few years. I think it's just right now we're trying to figure out where it fits in the paradigm. Why is that? Well, there's very ongoing studies looking at PSMA PET initial detection active surveillance, and it detects occult lesions in about 61% of patients. Of those, 28% end up having higher grade disease than they initially thought. It increased risk stratifications, increased detection of the clinically significant disease. On top of that, PSMA PET was found to have a lower false positive rate and a higher negative predictive value than multiparametric MRI. So I'm going to talk quickly about when I'm looking at this, when I'm doing assessment of reading these. SCV max has been associated, and this has been stuff that's been well established with the higher Gleason score, with if you use an SCV max of cutoff of 5.4, predicted pathologic upgrading of patients. There's the Istanbul PSMA PET CT criteria where they use various cutoffs. The 2 cutoffs that they used was 8.21, where they had an 83% sensitivity and 90% specificity of clinically significant, and pretty much aligned in the sand. If it trends up above 12, it's clinically significant prostate cancer. In addition to SCV max, so what is an SCV max? When a radiologist or a clinical nuclear medicine physician draws an ROI, that SCV max is just in one voxel. So if you may have a huge tumor and we draw an ROI around it, it's just taking a sample of that one thing. There's other metrics where we can measure the whole volume of tumor, so we can measure it and calibrate out. It gives you a volume that we can also calculate based upon that volume and the mean to give you the total PSMA uptake. That's been associated with higher Gleason scores at the time of surgery as well. I don't know how many of your radiologists or nuclear medicine physicians use the primary scoring. We have not used it, but this has been used very much in literature and substantiated with follow-up publications. What it is it scores things a 1 to 5, sort of using the PIRADS scaffolding where they said no uptake, it's a primary score of 1. Diffuse or heterogeneous uptake, 2. Focal uptake within transitional zone is a 3. 4 is focal peripheral zone, and 5, again, they use that SCV max of 12 for basically saying there's clinically significant prostate cancer. So let's go over some images. 68-year-old Gleason 4+5 disease, elevated PSA. This is a PIRADS 5 lesion. on the multiparametric MR, large tumor, probably had a little extracapsular extension with blurring on the periprostatic fat. Matching uptake, pretty large volume in the left gland on the PSMA PET MR. We're fortunate we have a PSMA PET MR, so a lot of our initial staging of biochemical recurrence we do on that. Now, where does PSMA PET really shine in this group? This is something that made our jaws drop when I started reading this. There's a nodal met in there. How about now? Right? No doubt about it. It's like a light in a dark room. It really shows up. To see that node on the MR list, you have to zoom in, and then you have to put an arrow on it to really say that's where that node is. But on the PSMA PET, pretty clear cut where that is. How good is it though? So how good is PSMA PET in lymph node detection? There's a wide range, but the weighted sensitivity is 60%. So we're not near the holy grail of getting every single node saying that is going to be cancer in that node, but it's much better than where we were, right? Better than CT, where we're waiting for the lymph nodes to get at least greater than a centimeter in the pelvis and 1.5 in the retroperitoneum. Much better than even when we combine the multiparametric MR with the dynamic contrast enhancement and diffusion-weighted imaging. Here's a 60-year-old, very elevated PSA, so we're already concerned that this has left the box, and so we're looking for systemic metastatic disease. Large bilateral tumors on the multiparametric MR in the left gland and the right gland. Here's the PSMA PET MIP image showing concordant uptake in the left gland and right, pretty sizable volume of PSMA uptake in that left gland. The patient was originally already scheduled to get radiation of the prostate and the pelvic sidewalls, but the PSMA PET found something that altered this patient's management. This was a presacral lymph node. This was not included in the original radiation field mapping, so this guy had our radiation oncologist then included that, and that's how they treated it. The literature says that it changes management in about a third of cases, PSMA PET MR. Here's another case, 72-year-old Gleason 4+4 disease, mildly elevated PSA. I don't know why a lot of my cases all fall off in the left-hand side of the prostate and the prostate bed, but they just do. That's selection bias. PIRADS 4 lesion, matching T2 and diffusion. Matching PSMA uptake. And here's that PSMA PET MIP images. So in this patient, we saw that there was concordant uptake. We're very confident that there's no PSMA avid, nodal, or osseous mets. So does this patient need a pelvic lymph node dissection? So that's a question that's been asked and being looked at quite clearly in literature. I already showed you the sensitivity is 60%. So per the NCCN guidelines, no negative PET, you still have to do it based on nomogram analysis if the patient has risk factors for needing a pelvic lymph node dissection. It doesn't really help you. What it does do is it tells you that prognostically there is a negative lymph nodes on PSMA have a lower rate of biochemical recurrence. What is interesting is a recent paper that came out that looked at it in a subtype of patients with intermediate risks. This study found that the negative PSMA PET had a high specificity and negative predictive value, and that because of that pelvic lymph node dissection may be admitted in this group. So this is a retrospective analysis, so this has to be vetted out and done in a prospective cohort. What about PSMA PET and driving local regional therapy decisions, especially with HIFU? PSMA PET actually has better definition of the overall tumor volumes and detects the bilateral disease more than multiparametric MR. Remember, I was talking about the ability to detect occult lesions not seen on the MR. In a recent study, in fact, that 1 in 10 patients, they found that PSMA PET would identify patients that were not suitable for HIFU, either from detection of additional sites within the prostate or metastatic disease. But it did find that the patients that underwent HIFU and PSMA found an improved failure-free survival rate compared to multiparametric MR. So it's the synergy of this with directing local regional treatment management. This is a study that I came across actually last night when I was going through. If anybody looks through PubMed, the number of papers coming out on PSMA PET is going up every year. It was 260 of them last year. So I always am like looking through and they're coming through on my email chain, but I thought this one was pretty interesting, where they looked at the impact of PSMA PET on staging initial treatment management decisions. This one was a newly diagnosed, so this is the NCCN guidelines where they have unfavorable intermediate, high risk or very high risk patients. And they compared PSMA PET to bone scans. So then they looked at patients who got PSMA PETs, what the management was done in that, and the patients who got bone scan. And what they found is that the patients who got PSMA PET actually had an increased number went on to systemic therapy, decreased number of patients went on to prostatectomy. Radiation therapy didn't really show much change. So it's going to be interesting. It's going to be interesting to see how this bears out. But I thought this was an interesting paper on the impact of PSMA PET in management choices with these patient cohorts. So one last group, one last study, looking at one last case. This is a 75-year-old elevated PSA. This is an classic anterior fibromuscular stromal tumor, lentiform tumor in the anterior fibromuscular stromal, comparable uptake, restricted diffusion. So I showed you multiple cases of intense uptake on the PSMA PETs. I was expecting that when I read this PSMA PET, when I looked at the MR. And this is what the PSMA PET looked like in this patient. That uptake anteriorly is actually the bladder. We looked around. We actually double-checked to make sure we had the right patient when we looked at this. We followed this patient to surgery. Turned out, which one is positive? Which one was wrong? The MR or the PSMA? Correct. The PSMA was wrong. This was the one with the surgery. It's a pretty sizable tumor, Gleason 4+3. This highlights an important thing. While the vast majority of our tumors are going to be PSMA expressing, greater than 90% of them, not all of them do. So if it looks like prostate cancer on the multiparametric MR, don't say like, oh, it can't be prostate cancer. So moving on to our biochemical recurrence cohorts. Again, I don't know why. This is why another patient with recurrence in the left prostate bed. On the multiparametric MR, this is what our most sensitive sequence, sensitive specific sequence is the post-contrast enhancement. Matching uptake, well, PSMA PET really helped us make more confident, but on top of that, we got systemic assessment. Here's the MIP image in this patient with local recurrent disease. What did we see here? This. So nothing in the pelvis, nothing in the retroperitoneum, but on the fused PET-MR images, we saw the patient had oligometastatic osseous disease, and they went on to SBRT of those mets in the PSA and went to non-detectable after treatment. So I just want to talk about a little bit of the clinical impact that this has had on biochemical recurrent cohorts. It's a flip of a coin. It's actually 1 in 2 patients that you're going to see a change in management. Like in that case, it's going to add a new radiation target or a new area of going to surgery. But I think the big one I always like to highlight is the number of patients that you can stem off doing systemic therapy. It drops in about half, going from about 26% to 12%. So speaking of systemic therapy, what about the androgen deprivation therapy? This a lot of times comes up. When can we start them on androgen deprivation therapy, and when can we get our PSMA PET? There's very heterogeneous impact on PSMA PET. Early on, you'll see this flare phenomenon where the PSMA intensity will go up, and then the amount of time it's on there will slowly go down. But the exact course and exact timing is not well known. So right now in biochemical recurrence, NCCN recommends PSMA PET done prior to ADT. So this is a patient elevated PSA after prostatectomy. This is a patient, again, done on our PET-MR, showing focal uptake right midline. So this was originally read out by our nuclear medicine attending who said, oh, focal uptake, that's just urethral uptake, physiologic excretion in the urethra. Fortunately, because we did this on our MR, and I'd actually advocate that every patient that when you're doing local recurrence assessment, when you're fighting what's urine and what is not, to get some type of cross-sectional post-contrast imaging, more preferentially multiparametric MR for this very reason. So we see that enhancing nodule. That enhancing nodule is actually separate from the urethra, and that was the local recurrent disease. So this ended up being local recurrence was sought in the prostate bed and no evidence of metastatic disease. So how does PSA level impact our PSMA positivity? This is a well-known phenomenon. The higher your PSA level, the more likely you're going to have a PSMA-avid disease. But the question is, what about this range? What about these low PSA levels? So what factors are influencing our PSA positivity rates? Is it our tracer? No, really, if you look at all three, they all have PSA sensitivity rate about 30%. There is some factors that influence, such as PSA level, the doubling time, and Gleason scoring that will impact our positivity. I thought this is an interesting study that came out recently. I talked about our technology. So they looked at these whole body PET CTs. I don't know how many of you have ever seen them or know what they are. They're really highly sensitive where you almost can do the whole body examination on one camera. So you don't have to do a image. You can just basically sit underneath the SAM. If you look at the two, you can actually see that it's about 30% more sensitive than you're doing those standard short axis field of views. And lastly, this is a study that came out of the Mayo Group and looked at PSMA PET in patients with non-detectable PSAs. They actually found PSMA-avid disease in this cohort in about 1 in 10 patients. So here's a PSMA PET biochemical recurrence. This was done 2 in a row. They were all negative, and I'll say there's nothing on here. So this patient went on to another examination called FACBC, the oxamin or cyclophene study. And we looked at the axial PET in this patient. There's actually a lymph node that was not positive in the PSMA PET. So there's an FACBC positive and the PSMA negative lymph node. So let's talk about the significance of what we see when we have a negative PSMA PET. I think you have to be very careful. A negative PSMA PET does not equal no disease. It may just be that there's not enough tumor, as I showed you with specificity of our scanner type, to be detected on the machine. So there's 3 strategies after a negative PSMA PET. Just treat them. Lower than PSA, you can treat them with salvage radiation. There's data to support that this actually has a treatment improvement. You can just repeat the PET in about 1 in 2 patients. You'll then end up finding the disease. You just do a follow-up, and you can see the PSA trends. Or you can consider, like we had one that had multiple PSA scans. The NCCN guidelines will actually, in the AUA and the Astro, would recommend doing an alternative agent. The one that they suggested would adding fluciclovine, or we did in that patient over conventional imaging. If you think the patient has poorly differentiated disease or neuroendocrine tumor, you can also do an FDG PET. We're going to talk a little bit about some pitfalls. This is a 68-year-old elevated PSA after prostatectomy. If you ever have an inexperienced radiologist who's not used to reading these PSMA PETs, always be cognizant if they call something in this region. If you see like a high retroperitoneal lymph node, retrocaval, they may be actually being mistakenly calling this because this is not a lymph node. This is a ganglion uptake. They're quite common in our PSMA PETs. Ganglions are potential pitfalls with our PSMA PETs, where you can see them in cervical ganglion, celiac ganglion, or presacral ganglion. Another potential pitfall is any uptake in the chest walls along the ribs. If I ever see this, and I'm confident it's in the chest wall, I look very closely at the ribs. This is an example of a false positive PSMA PET because of acute rib fractures. In fact, rib lesions we see all the time. It gets to the point where if I see low-level uptake, I just ignore it. Low-level uptake, we see it all the time. Just as a radiologist, I will just not even mention it. Sometimes we'll see in other bones, like in this case, we see heterogeneous PSMA uptake in the right iliac wing, but on the CT, it has that classic appearance for Paget's disease. One last thing, this is again another potential pitfall. Focal uptake, patients got all extensive metastatic disease, uptake in the left neck. This ended up being uptake in the left thyroid gland, so metastatic disease, left thyroid gland, got a biopsy. This ended up being papillary thyroid cancer. On top of that, they had focal uptake in the left cervical node. So is this a Varco's node, or is this metastatic papillary thyroid cancer? Got biopsy and surgically confirmed to be inflammatory lymph nodes. So 3 different processes, same patient. So it really brings up, is that S a misnomer? I think so. It's really, really sensitive, but not 100% specific. It can be seen in malignant entities and benign entities. So in general, I use my mantra, if it doesn't look classic for prostate cancer metastasis, think about other synchronous processes, either benign or malignant. This is a case that threw me for a loop I read recently. This is focal uptake in the right base. We had uptake up in the left upper quadrant. This ended up being focal uptake in the spleen. This ended up being uptake from a splenic hemangioma. This was stable over 5 years. So just highlighting pitfalls, ganglion uptake, solitary bone lesions, especially common in ribs, and second primary. Let's quickly highlight some of the roles of PSMA PET in systemic therapies. This has been growing and growing. I'm not going to spend too much time on this. But what is it? Now we swapped out that positron emitter for a beta emitter. 200 millicuries is the same dose for every patient unless there's some type of renal impairment. We'll sometimes do a de-escalation. All patients get up to about 6 infusions, 6 weeks apart. The part of that screening is we get that PSMA PET CT to make sure that they have PSMA positive disease. So what do we do if the patient has PSMA negative disease? What is defined PSMA negative disease? Well, that is a soft tissue lesion greater than a centimeter. Therapy is generally not recommended in patients with a dominant lesion. How do we find these lesions? Well, we can look at it for a FDG PET if they got poorly differentiated disease, or DOTA PET in neuroendocrine subtype. Show you an example. This is a not too uncommon example of extensive osseous metastasis, elevated PSA. This was, we draw their PSA right before therapy, showing the PSA was still starting to rise. And after 3 infusions, PSA went down to 1/10 and decreasing the size and number. Some future clinical applications, I sort of already alluded to them, active surveillance groups. And then on top of that, systemic therapies in terms of one of the things that we don't really have clearly defined yet is PSMA treatment response criteria. And then trials, we're looking at not only PSMA PET therapies in various cohorts, but on top of in combination with other therapies. So key takeaways here is PSMA primary indications, initial staging, biochem recurrence, and systemic therapies. Especially sensitive at low PSA. It's not as specific. Remember, think about other processes, including benign or malignant lesions. Be careful with solitary bone lesions, especially in the ribs. Not all PSMA PET cancers are PSMA avid, especially patients who have undergone multiple lines of therapy. They may develop and dedifferentiate and become FDG avid. And PSMA-based therapies are FDA approved for patients with with castrate-resistant prostate cancer. Well, thank you all very much. I think I have time for a few questions.
Yeah, absolutely.
Thank you very much. Alexander Govorov from Moscow, Russia. Could you make a comment once again about normal SUV max? Does it exist? Or is it similar in different places, different center, or it may be different?
So there is some variability. So the SUV values will vary a little bit about what scanner you're on and some of the technical aspects of it. So that's why I always take it as, I wouldn't fall in line and say like, if this one's an 8, therefore it can't be cancer, and this one's an 8.4, or if this one is 11. So I always try and read, and I'm always very careful in FDG, PSMA, any scanner I'm looking at it. It's just guidelines to help with it. Is that sort of like what you're asking is like the cutoffs and those values?
Well, difficult question.
It is. It is something that is still being clearly defined. And the positron with the gallium agent versus the F-18 is a little bit different as well. So you're going to see a little bit different values because the positron from the gallium is a little bit different than the F-18.
Okay. Some people do PET MRI.
Yes.
What is the current status between PET CT and PET MRI? Just
you mean in terms of interpretation, in terms of more than multiparametric MR?
What is my indication to order PET MRI instead of PET CT?
So we're at UCSF, it depends on where they've fallen into the paradigm, right? So we have a lot of patients who come out from UCSF who've already had the multiparametric MR. They will then, if they already have that, then we'll just get a PSMA PET CT. If, let's say you had a patient who doesn't have any other imaging, biochemical recurrence group and the patient with the high risk, intermediate, unfavorable intermediate, and the very high risk groups, or if they have very high elevated PSA in initial staging, we'll try and put them onto our PSMA PET MR.
Okay, thank you.
Thank you.
Hi, nice presentation. And when you have a biochemical recurrence, so is there a cutoff for a SUV that drives you to think that this is a false positive? Like if you have a node that's the SUV is 2.5, how will you interpret this?
That's a great question. So I use a little bit of a probability map too. So blood pool, some people like to use is it's greater than blood pool, and if it's in a good location for a MET, I will read it. Let's say you're sitting there, blood pool is 2.1 SUV, and I look at it's 2.5, but it's left internal obturator lymph node, and that was the side of the cancer. I'll tend to say it's like, look, it's low-level uptake, but given the location, it's suspicious. If it's a groin lymph node or a neck lymph node, and it's 2.5, I tend to let them go, because you're going to see some inflammatory uptake with those. Sure.
Thank you for a great talk. why do you think there's a reluctance to use lutetium PSMA in earlier stage hormone-sensitive prostate cancer?
I think reluctance, I think people are, for example, I had a patient who really didn't want to go through it, and he did it, and we did it as an exception for hormone sensitive. I think because it is radiation, right? I think this is something that is not as well known. And I didn't talk about the side effects, but I treat patients with neuroendocrine tumors all the time with Lutathera. 10% of those patients end up developing leukemia and myelodysplastic syndrome within 3 to 5 years after therapy. So there is not a benign side effect, and the salivary gland side effect is also another thing. So the patients will develop dry mouth. But the other question that sometimes that people are looking at is post-prostatectomy, where we use a lower dose. So, but that's why. That's one of the reasons. Okay.
Great, thank you.
Tracy.
Okay, thanks very much for the opportunity to talk. We're going to switch gears a bit here to talk about use of PET imaging in germ cell tumors, which has had a little bit less action than in prostate cancer over the last few years. Sorry. There we go. So what I'm going to review today is the different potential places where we could use PET in germ cell tumors. So initial staging, which has been studied in a number of different ways. The evaluation of post-chemotherapy residual disease, which is really where it fits in guidelines. Prediction of early treatment response in germ cell tumors, and then use of novel tracers and future directions. So most of the data comes into initial staging for germ cell tumors. Obviously there's non-seminoma and seminoma, and we use PET and imaging in different ways between the two entities. So to go through the non-seminoma data first, this is really one of the earlier studies that looked at whether PET augments contrast-enhanced CT for initial staging of non-seminomatous germ cell tumor. So these were patients with stage 1 or 2 disease that had primary RPL&D and had a PET scan prior to surgery. It's notable they under-accrued, so they didn't meet their accrual goal, so this is an underpowered study. But 26% of the patients that they took to surgery ended up having pathological nodal involvement. And they did not reach their primary endpoint, showed a negative predictive value of 78%. And so here is the data. So if you look at CT and PET, neither of which are all that sensitive, 41% for CT and 66% for PET for stage 1 or 2 non-seminomatous germ cell tumors, both highly specific. But the negative predictive value really for CT is 67% and PET is 78% based off this study. If you include both, it increases the numbers a little bit. But this was felt to not improve the statistics compared to CT alone, although it does numerically improve sensitivity a little bit. And this is another study, similarly, that was stopped early, but essentially looked at a cohort of patients with PET-negative disease. So these are all stage 1 patients with non-seminomatous germ cell tumor, but with risk factors, so LVI. And then if they had a negative PET, they underwent surveillance. And so it was trying to show that you could help risk stratify these higher risk stage 1 patients with PET. And you can see the 1-year sort of relapse free rate was only 63%. And so they were not able to meet their primary endpoint, and trial was stopped early. So you can see that really a negative PET in the setting of stage 1 disease does not help us decide who can safely undergo surveillance. And overall, the non-seminomatous germ cell tumor, these numbers really don't support using PET and is not incorporated in guidelines. Switching to seminoma, the numbers look relatively similar. So this is a larger study, about 166 patients with stage 1 seminoma had a PET CT. Nearly all of them were negative. So if you don't pick up disease on a contrast-enhanced CT, it's unlikely that you'll pick something up on PET. So 96% of the patients included ended up with a negative PET. Only 6 patients had a positive PET. And then out of the 160, 22 patients with a negative PET ended up relapsing, so 15%. So again, not highly able to discriminate the patients that are going to relapse. This is a secondary analysis of the SEMS trial. So as many of you know, primary RPLND for stage 2 seminoma is an emerging and increasingly used way to manage these patients. So within the SEMS trial, which is sort of the prospective trial looking at primary RPLND and stage 2 seminoma, they did PET scans on patients prior to surgery to try to see how well it discriminates and predicts pathologic staging. And you can see it actually did pretty well. So out of the patients that were pathologic node positive that had scans, 18 had a positive PET scan, only 1 was negative, so that's a sensitivity of 95%. And out of the patients that had negative nodes, PET was positive in 2 and negative in 5, so a little bit less specific, 71%, positive predictive value 90, negative predictive value 83. So, these are pretty good numbers. However, these are all patients who had stage 2 seminoma, so had detectable nodal disease on their CT. And so does this actually change management? Are you going to use this? No, it sort of correlates with nodal staging, but CT was able to identify all these patients, so it really doesn't change management in this setting either, since the pretest probability of having disease is quite high even without the PET scan. So really for initial staging in both non-seminoma and seminoma is, PET is recommended against in guidelines. The small increases in accuracy are, not outweighed by the downsides and the costs, and it really doesn't change management in many cases. And so really the meat of where guidelines incorporate PET in germ cell tumors is looking at the assessment of residual disease after chemotherapy. So in non-seminomatous germ cell tumor, there's really no role. FDG PET is only marginally better than conventional imaging for assessment of residual disease. And so in this study, 85 patients with non-seminomas and had residual masses were evaluated with PET after primary chemotherapy. You can see PET had a sensitivity of 59%, specificity of 92%, and really a negative predictive value here of only 62%. Similar numbers overall to conventional imaging with CT or MRI with a negative predictive value of 58%. Again, maybe a slight increase in positive predictive value and sensitivity, but really no different. And the reason here is that unfortunately, a lot of what we talk about with non-seminomas and residual disease is their teratoma component. And PET really cannot differentiate teratoma versus necrosis or scar. And so, part of the reason we resect all patients with residual disease with non-seminoma is to make sure we take out teratoma, this chemotherapy-resistant tissue, and PET really can't tell us if there's teratoma or not. There's one suggestion of sort of using kinetic rate, but it's not very well validated. And so even in post-chemotherapy for non-seminoma, PET really has no role in the management. And so really the heat of the discussion here is in the seminoma population. And so we know actually that the best predictor of residual disease for seminoma post-chemotherapy is the size of the residual mass. And this very well predicts the likelihood of viable seminoma after chemotherapy. So if you have a patient with a residual mass of less than 3 centimeters, the chance of viable cancer remaining is really less than 10%. And you can see there's multiple studies here that show that rates are quite low if it's less than 3 centimeters, and double-digit chance if it's greater than 3 centimeters. And so the first step is conventional imaging after chemotherapy. If you have a mass less than 3 centimeters, then you're done, and the chance of viable disease is quite low. And if your mass, however, is greater than 3 centimeters, then what is the role of PET? So the FDG avidity, so these are FDG PETs, is really one of the predictors of post-chemotherapy residual seminoma. All this data has evolved over the years. The challenge is that these seminomas have these, as many of you know, these profound desmoplastic reactions, and so you can get false positive FDG avidity in the staging or in the post-chemotherapy setting. This is also some of the drivers of why these are demanding surgeries with high morbidity post-chemotherapy. And so, post-chemotherapy surgery for seminoma is much more rare than for non-seminoma, is really done at high-volume centers because of the difficulty of the surgery, and that plays into how we decide who to take to surgery. So the initial study that really got PET in guidelines for seminoma in this context was the SEMPET study, where 51 patients with advanced seminoma underwent post-chemotherapy PET-CT. And you can see, compared to conventional imaging, this study really showed an improvement in positive and negative predictive value, mainly in the positive predictive value. All lesions greater than 3 centimeters in this study were correctly predicted by PET. And this study is also the one that really solidified the timing of the PET after chemotherapy. So they looked at timing of scans, and overall 26% of scans were positive, and they really validated this 6 weeks post-chemotherapy metric as the timing of the appropriate PET scan after chemotherapy. And I'll just make a comment as a medical oncologist, this is actually 6 weeks after the last date of the cycle of chemo. So we think in cycles, you actually only get chemo sometimes for the first 5 days of the cycle, but it's a 21-day cycle, and then 6 weeks after that. So it ends up being a good 63 plus days after your first day of your last cycle of chemotherapy that you should wait to get a PET scan because of the high risk of false positives. And you can see that, it improves negative predictive value, both positive and negative predictive value, by waiting after 6 weeks compared to before. And as studies have evolved, this paper came out now a number of years ago, really questioning the role of PET in this setting, and took patients with a positive PET and then followed them over time. So these are all patients that had chemotherapy, had a positive PET scan, and in the setting of a residual mass greater than 3 centimeters, they looked at 95 patients. And out of the patients with this positive PET scan, you can see that 26 of them, or about 30%, had initial surgery. And out of those, about 20% had actually seminoma in the specimen, 8% later relapsed. So that's a relatively low number for patients with a positive scan that underwent surgery, only 20% in the specimen. You can see patients that underwent repeated imaging, which was actually the majority of patients in this. Similarly, about 20% had a relapse in the future, and those that had another PET and then had a resection after that, you got the numbers up to about 30% of patients with seminoma in the specimen. So repeating imaging can increase the likelihood that you're going to find disease at RPL and D if your PET remains persistent. However, if you look at the total number of patients that had positive PET scans, and then those that ended up having either seminoma in this specimen or relapse later, the positive predictive value here is only 23%. And so that it would be sending a lot of patients to surgery for a very morbid procedure with a pretty low positive predictive value. And they tried looking at, can we predict this better? Can we look at SUV max? Can we look at time from chemotherapy? Can we look at size of residual mass within that greater than 3 centimeters, or unequivocal results? And it was really hard to find something that can improve positive predictive value here. And the other thing to say is that all but one patient in this cohort were treated successfully with salvage or high-dose chemotherapy. So there is a curative treatment option for those that do relapse. So these are the guidelines for NCCN a few years ago, and you can see, so you have your seminoma, you got your chemotherapy. If there's a residual mass greater than 3 centimeters, it used to say surveillance or PET, and then if it was a negative PET, you're done, surveillance. If it was indeterminate, guidelines used to say repeat PET, and positive, either resect or biopsy. And they've actually been updated now based off some of this data, questioning the use of PET, to say, okay, residual mass greater than 3 centimeters, surveillance or PET, that's the same. Now, if it's indeterminate, they just say go straight to surveillance. And it's very hard as a medical oncologist who's not reading these scans all by myself, sometimes with the interpretation of these post-chemotherapy PETs, because it's somewhat rare for the nuclear medicine team to come out and say, 100% this is a positive scan versus this is an indeterminate scan, right? It's sometimes a little subtle to interpret these. These are hard scans to read post-chemotherapy, but they've changed it essentially. Indeterminate scan, surveillance, and now even if you have a positive scan, repeating imaging is a very reasonable option, I think, based off some of this data. And so if you look at the EAU guidelines, they essentially say when a post-chemotherapy mass remains positive at reclassification with FDG PET with no volume increase, repeat PET should be performed 6 weeks later. A recent publication, that's the one I just showed you, shows a low positive predictive value. Therefore, caution is recommended with PET as a single parameter to drive clinical decisions in a persistent mass. And so if you look then at, well, how do patients do if you do send them to surgery versus wait for relapse and treat them systemically, you can see this paper from the Indiana group actually looked at long-term outcomes of the patients they took to surgery. So they looked at the 36 patients who they had taken to surgery who had viable disease there, and the 5-year cancer-specific survival was 54%, but actually only 25% of those patients remained cancer-free. So if you do an RPLND, post-chemotherapy for seminoma, if you find tumor there, so the hope would be that if there is tumor there and you take it out, you are now curing those patients, right? That would be the goal of the surgery. You're only successful in that about 25% of the time based off this. So that sort of questions the role post-seminoma RPLND anyway. And so they make the comment, viable seminoma is particularly resistant to local control. And then if you look at the same group looked at their sort of high-dose chemotherapy outcomes for relapsed or progressive seminoma. Their 2-year PFS rates were about 90%. There's clearly a lot of long-term toxicity with the high-dose chemotherapy regimens, but they are curative intent treatments that cures a lot of patients. So, in summary, given the low rate of residual disease, post-chemotherapy, if you have a mass less than 3 centimeters, surveillance is recommended. You don't even need to do a PET scan. Consider a PET scan if you've got a tumor greater than 3 centimeters. If it's negative or equivocal, data favors surveillance. Even if it's positive, consider repeating imaging down the line, and then think hard about taking these patients to post-chemotherapy RPLND. This is very different than the non-seminomas, right? So, I'm a big advocate for post-chemotherapy RPLND and the non-seminomatous germ cell tumors, but it's pretty rare that I have a patient that needs surgery or should have surgery post chemotherapy for seminoma, and then consider salvage chemotherapy at unequivocal progression. So this is a patient, the first scan after BEP, and then had progression in the retroperitoneum, got TIP, and then, you can see on that last imaging there, still has this very ill-defined abnormality in the retroperitoneum. You can see, this is a lot of what our scans look like, where you can see some residual FDG uptake there in the left retroperitoneum. And, we'll get back a read that says something like retroperitoneal adenopathy described on prior is less avid, but still significantly avid above blood pool, right? And so, what is that positive? Is that negative? It sounds kind of equivocal, which is what we did. We just monitored this patient who is still cancer-free. So the other place that has an evolving role but no real clinical utility yet, that we don't yet use clinically, is, can we use PET to de-escalate therapy or determine early treatment response that can help us choose therapy? So this is one of the earlier studies essentially looking at whether doing a PET mid-treatment can predict long-term outcomes that showed that, yes, it can help. And then there's been a couple prospective studies looking at using PET to de-escalate therapy. So this is a study that actually did a very early PET. So they had patients with metastatic seminoma gave them their first cycle of chemotherapy, and then did a PET at the end of the first cycle, and then based off that decided how many further cycles of chemotherapy that they were going to give. Similarly, this is the SEMITEP trial, which also treated metastatic seminoma, gave patients 2 cycles of standard chemotherapy EP, and then after cycle 2 did an early PET scan. If the PET was positive, they completed the standard 4 cycles of EP. If it was negative, though, they just gave 1 more cycle of carboplatin and really de-escalated the rest of the chemotherapy with the theory that if we can use PET as an early treatment response predictor, we can minimize long-term toxicity. You can see out of these patients, a lot of them had a negative PET. They enrolled 102 patients, 98 got a PET, 71 ended up having a negative PET and going on to that carboplatin, 67, I think, because a few patients wanted to get the standard chemo. And so it was relatively rare to have a positive PET even after 2 cycles in this setting. And you can see the progression-free survival was the same on both arms. So one might, theorize that EP plus carboplatin may be a little bit less effective in terms of cancer control, but with similar outcomes, and probably most importantly, decreased incidence of neuropathy and your toxicity. And, that being said, there's really no validated metabolic response criteria. It's hard to interpret these scans, so it's, very hard to disseminate this into clinical practice, and we really don't have randomized comparative data to support this approach at the moment. So we really need some sort of prospective studies to show that this is a good approach. So they've tried some other tracers, some theranostics. Nothing has really panned out yet in the germ cell world. There's been a paper looking at 177 lutetium as well as some other tracers, but nothing that's standard. There's been some efforts to try to figure out if we can use different tracers to pick up teratoma. I think the heterogeneity is a challenge, and so this study didn't work really, and looked at just 10 patients and really couldn't differentiate. And then PET in the germ cell world, not unlike a lot of our other tumors, is really coming up against some of the minimal residual disease markers that we have. I put in microRNA here. There's been multiple new papers also in the last couple years looking at this specifically in seminoma about whether, if these markers are going to be better at predicting whether someone's retroperitoneum has disease or not compared to PET. My guess is probably that these are going to supplant PET. And I don't have a slide, but talking about CT circulating tumor DNA also has been looked at in early papers in germ cell tumors, much like many of our other tumors, and does look like predictive for relapse, et cetera. And so, I would anticipate that our guidelines won't change in terms of use of PET for initial staging, and may even change once these microRNA and ctDNA evolves further to use that rather than PET after chemotherapy, what we shall see. And this is just some of more of the microRNA data sort of showing that it can predict progression-free survival. So, in conclusion, there's currently no role for PET in non-seminomatous germ cell tumor that includes initial staging and post-chemotherapy. FDG avidity has a high negative predictive value for post-chemotherapy residual seminoma. Negative PET after chemotherapy and seminoma means surveillance. Management of FDG avid residual seminoma in greater than 3 centimeters is nuanced. RPL&D and surveillance are both good options, and I favor surveillance for most of my patients. And PET may be used to predict early treatment response and de-escalate chemo, but this remains investigational.
Any questions from the audience on testis cancer? Thank you again. So thank you for making it to the last topic. Let me see. I pull this one up. Pull it up. I think if anyone has registered for the course, at some point you may get some multiple choice questions that just kind of checks if we kind of hit on the course objectives. And the other thing that you may receive, which is probably equally important is our mind, is some type of feedback on the course, whether there was a course informative, whether it was educational, did it meet the needs of the audience. So any type of feedback you could give would be great, because this course is looked at by the AUA. And if it's beneficial, we continue it. If it's not meeting the educational needs, we either transition to try to meet those needs or sound down this course. But any feedback will be greatly appreciated. And with that, we'll start our last section on bladder cancer. In terms of an outline, we'll look at a little bit on the current radio tracers. We'll talk a little bit about primary tumor staging, and then there's some techniques we can do to improve that. We'll then transition to lymph node staging, look a little bit at neoadjuvant chemotherapy response. This is actually a little bit outdated given the era of EVP. A slide or two on bone metastases and bladder cancer and imaging. We'll look at some emerging radio tracers, and then what do the national guidelines have to say about PET imaging for bladder cancer management. So which radio tracers do we use and why? Well, in terms of soft tissue, really FDG is the one that has been largely the workhorse of bladder cancer. It's advantageous for a number of reasons. It's been widely available. It's really familiar in terms of interpretation. It's used for a number of malignancies and has high sensitivity for osteolytic lesions. One of the main drawbacks of using FDG PET imaging in bladder cancer staging is the radio tracer pools within the collecting urinary system, so it's quite hard to use it as a primary staging tool or any assessment of lymph nodes around the bladder. There's been some work done on the C11 agent, C11 choline and acetate. The benefit is there's minimal excretion in the urinary system, so it's better for kind of pelvic staging. The drawback is really it has a short half-life, and you need an on-site cyclotron for those, which makes them very limiting. In terms of bone imaging, really the technetium scan remains the standard of care, widely available, highly sensitive, and it's probably driving this largely to maintain in guidelines as it's low cost. There are some disadvantages in terms of false positive for benign lesions. And alternatively, there's a sodium fluoride PET CT. This is more kind of the formal molecular imaging modality, but even though it has improved characteristics and sensitivities, this is not widely adopted into care, and we'll get into a little bit later. So in terms of primary tumor staging, we'll talk a little bit about some pitfalls and some diuretic techniques, and then we'll touch base on the VIRADs. But you can see here the limitations of using FDG in bladder cancer staging is the radio tracer largely pools within the bladder, so you can't see the actual primary tumor or really any lymph nodes that are closely associated with the actual bladder itself. On the screen, the picture on the left is the radio tracer pooled, and you can see on the right that large tumor on the lateral wall that was entirely obscured by the pooled radio tracer. In terms of options and how to overcome this, there has been some trials that have looked at diuretics to try to really force that radio tracer out of the bladder. Patients would be administered the FDG. They're asked to drink water, a half liter or so. Sometimes they're given Lasix, 20 milligrams IV, and then have the patient void. They're scanned early, then they again have a delayed scan at a later time to try to really force that urinary tracer out to get a better picture of the bladder. Here's an example on how that's improved the visualization of the urinary bladder. Top left image, you can see 60 minutes after the FDG radio tracer has been injected. Largely avidity in the entire bladder, can't make out much of the tumor. The slide underneath that is an hour after 20 milligrams of IV Lasix. Patient consumes some water and they voided. You can now see residual tumor that may be beneficial for primary tumor staging. The images on the right side of the screen just show interim evaluation after neoadjuvant chemotherapy. Again, pre-IV Lasix, this is in the top right. After the patient drank some water and voided, we can get a better picture that there's still residual disease in the bladder that now can be used for some type of primary T staging. Has this been adopted in the clinical practice? Not necessarily, but there is a couple of studies that looked at, can we at least predict whether there's disease going to be there? This study by Yan and colleagues, 79 patients who underwent a TURBT. About a month after their TURBT, they both had a CT PET and then got the delayed diuretic. They took those patients back to the operating room, got a repeat TURBT on all 79 of them 2 weeks later. 35% of those patients had benign tumors and 65% had residual malignant disease. And what the team looked at is in those patients that had uptake in their diuretic PET CT, could that then correlate with residual disease? And you can see here that the SVU mean, the SVU max, and then the thickness of the actual bladder wall and tumor all correlated with residual disease. They then came up with a risk stratification system saying, you know what, if you fell in the low risk category, 37% chance you'd have malignancy, moderate or high risk, much higher chance of having residual disease. Helps risk stratify our patients, but it may still be challenging to adopt into clinical practice. Looking at kind of a review of the literature for primary tumor staging, you can see here a number of studies have looked at different radio tracers for primary tumor staging. Sensitivity is quite broad. Specificity is even broader, ranging from 0 to 100. And given these kind of characteristics that, again, this has not been widely adopted into practice for primary T staging. I know MRI VIRADS is not a molecular imaging technique, but I just wanted to put one slide in here because I think this is the standard of care if you're going to get an imaging test to look at T staging. It's been validated across the entire globe on a number of different cohorts from a number of different institutions. You can see here that the sensitivity is quite high, specificity is fairly good. Area underneath the curve is also well reported, anywhere between mid-80s to upper 90s. So VIRAD is probably our imaging choice of staging when we want to figure out T stage. Switching gears a little bit to lymph node staging, we'll talk about FDG PET versus CT alone. How does this change our management, and then some alternative radio tracers. When we do get FDG PET imaging tests, it's often to look at regional lymph nodes and distant metastatic disease, and it performs fairly well, pretty much on par, though, in what we already have. In terms of head-to-head comparisons, looking at contrasted CT versus MR versus FDG PET, you can see slight differences in the sensitivity, 40 versus 60 versus 56, and this kind of varies throughout the literature depending on what you use as the standard reference. And the specificities are all pretty much identical, low 90s. So it kind of begs the question, is there really an advantage of FDG PET over our standard imaging? And that's been assessed in a few studies. This is a Scandinavian group that looked at just over 100 patients who were all fit for cystectomy. They underwent both a contrasted CT scan as well as an FDG PET, and they looked at what would be our plan based on the CT contrasted imaging, and then what would be our plan based on the FDG PET. And you can see here that the FDG PET actually showed metastatic disease in 47% of patients that were not seen on CT. It kind of begs the question, what were these metastatic disease? If you already had 2 lymph nodes in the pelvis and now you found 3, is that really going to change management? Well, they did find it did alter management in about 27% of patients. You can see here 16 had their cystectomy canceled, 12 extended their neoadjuvant chemotherapy, and there was a couple of delayed treatments for false positives. Looking at treatment recommendations based on FDG PET, this is probably one of the largest studies out there published in European Urology a couple of years ago, 711 patients with muscle-invasive bladder cancer. You can see here that it changed the actual stage in 26%. Largely, these patients get upstaged because of the higher sensitivity for picking up lymph nodes. Most commonly was seen changing from clinical M1A to clinical M1B, so those, again, the distant lymph nodes, that was an upstaging in 44%. And you can see the treatment changing here. You can see that about 20% were changed in terms of their local treatment plan, 13% in terms of local treatment plus chemotherapy, and then 8% for palliative treatment. But an overall change rate of about 16% based on the findings from the FDG PET. Which then leads us to the next question, well, is PET MR better than actual FDG PET? And there's only been a couple of studies that looked at this, and you can see, again, kind of overlapping specificities to prior slides. We saw somewhere in that 40 to 60 range. Sensitivities are a little bit higher. One study, unfortunately, didn't have actually any positive lymph nodes during dissection, so you can see their sensitivity was 0. This topic has been kind of controversial in the literature. This was published just the other year. You know, Dr. Sam Chang from Vanderbilt used to write the urological review section of the Journal of Urology, and he commented on this paper just the other year. The paper you can see here is Staging Using FDG for Bladder Cancer. And Sam actually brought up this exact question we're talking about today. Do I routinely order FDG PET CTs when assessing patients with invasive bladder cancer? At least when this paper was written a couple years ago. At this point, he said he does not. Improving imaging accuracy for patients with possible advanced urothelial cancer is important, and perhaps other ways to assess, like its biomarkers, like we spoke about previously with Dr. Rose, circulating tumor DNA, will ultimately play a more influential role in management directions. So also good to get some experts weighing in on the topic. Looking at choline, this radio tracer has been studied as well in the setting of muscle-invasive bladder cancer. The benefit, like we highlighted earlier, is it has minimal excretion in the urinary bladder and collecting system, so there's less noise, better for primary T staging. But in terms of lymph node staging, it's typically on par with FDG PET. You can see here combined sensitivity somewhere in that 60% range, combined specificity around 89%. The forest plots on the left do plot out the sensitivity and specificity. You can see here it does slightly outperform that of contrasted CT scan. But the main drawback is the 20-minute half-life. So you do need an on-site cyclotron if you want to use this agent. And I made this comment in the previous years that we have an on-site cyclotron at our institution. It's just across the street, about 2 blocks away. In my 8 years of being there, I have never ordered a choline or acetate PET scan, nor have I seen any of my colleagues do it. So not widely adopted in clinical practice, even when you have an on-site cyclotron. Switching gears again a little bit in terms of can we use PET to look at neoadjuvant chemotherapy response. There was a nice study that came out of Canada just the other year. It was a trial that enrolled 291 patients who all got FDG PET scans in terms of assessment of their muscle-invasive bladder cancer. They had a small sub-study looking at neoadjuvant chemotherapy response. They got an FDG PET at the start of the study and then after 2 cycles of cisplatin-based neoadjuvant chemotherapy. And what they looked at is metabolic responders, and they did see in those patients that responded metabolically on that PET 2 weeks or after 2 cycles did have improved recurrence-free survival and overall survival. So it also kind of fits into our clinical context that maybe we can identify those patients who respond and go on to get the rest of their chemotherapy, as well as identify those patients who are not responding and they move straight to cystectomy. This was looked at in a number of groups, but this is one study I wanted to highlight, adopting that kind of strategy. It said patients would get FDG PET prior to their neoadjuvant chemotherapy. They get 2 cycles, and then they get an additional FDG PET, and we looked at, or they looked at assessment of SUV response. Essentially a 50% reduction in SUV was used to identify those patients that were downstaged. Those that were downstage, at least they had a partial response, could go on to get their additional 2 cycles of chemotherapy. Those patients that appear to not have any response on PET, they may go straight to cystectomy and try to avoid the toxicity of additional chemotherapy. In terms of bone metastases, we highlighted previously that sodium fluoride PET is really a better tool to assess bone metastases. However, the reason this has not been widely adopted, CMS in around 2015, essentially it's not essential or needed to assess bone in bladder cancer, and they stopped paying for it. So widely it came to a hard stop when it's rarely used in practice to assess bone metastases in the setting of bladder cancer. Perhaps what's the most interesting topic is what's coming down the pipeline. Is there something going to be out there better than FDG PET? And there's some interesting radio tracers. Fibroblast-associated protein inhibitors are coming down the pipeline, and I think that's going to be very exciting to see. We do know in bladder cancer tumor stroma that there is a high expression of fibroblast activation protein by the urothelium, and then if we can tag a fibroblast-activated protein inhibitor to a gallium-68 molecule, that we could then possibly pick up this type of disease. It has a couple of benefits here. You can see a small molecule inhibitor with a scan times of about 60 minutes. There's low urinary excretion, so again, we might be able to see the bladder and nearby lymph nodes a little bit better. And then in terms of preliminary data, there's been a few studies that have now assessed this. Most of them are, small, less than 20 patients, but you can see at least on the top left study, 8 patients, the SVU max was much higher than that of FDG. The fibroblast activated protein inhibitor detected 30% of additional lesions that were missed by FDG. Study in the right upper corner, you can see 18 patients, lymph nodes assessment pre-cystectomy, 229 lymph nodes were resected. In terms of positivity, there were 4 out of 7 positive regions in the fibroblast-associated protein inhibitor. 26% of lesions were missed on CT, so again, it speaks to the sensitivity and specificity of this potential radiotracer. And then lower right-hand corner, a group from Dr. Baer's team, localized bladder cancer. They used fibroblast activation protein and detected 9 lesions across 8 patients that were missed by conventional FDG. So potentially this may have a role in the future, and additional studies are pending. These are typically retrospective, not guideline endorsed yet, so just keep that in mind. Next, radiotracer that has some potential Nectin-4. We do know that Nectin-4 is overexpressed in urothelial carcinoma. This is quite high, somewhere around 70%, perhaps 80%. And as a result, the FDA has approved Enfortumab for this treatment. If you could take a Nectin-4 agent and then radio label it to a gallium-68, this could then probably pick that disease up. There's a first-in-human study just a couple of years ago. You can see here 14 patients, high specificity and sensitivity for Nectin-4 positive metastases, and it correlates with Nectin-4 immunohistochemistry expression. And really, the benefit is not only picking up disease, but you may actually be able to select patients that are most likely to respond to Enfortumab because they do have Nectin-4 expression. It has some advantages over tissue biopsy itself. You can see here, and again, lower urinary excretion, so it may play a role in assessing primary tumor. There's an ongoing phase 1 that hopefully we can report on next year. Dr. Baer mentioned how we can use PSMA PET for prostate, but there's also some role in potentially using it for staging urothelial carcinoma. You can see here PSMA is expressed in the bladder itself, just not the prostate. It's excreted hepatobiliary, again, so lower urinary tract excretion. And a small study here, you can see only 4 patients, but it did have a higher signal-to-noise ratio, picked up more lesions than FDG PET did. And the specificity was a bit higher. And what's also promising about this radiotracer is that, in the era of prostate cancer, that you can take lutetium onto it and turn it into a theranostics option. This may be a viable option for bladder cancer as well. So you could identify where the malignancy is and then treat it by the same modality. Girentuximab. Dr. Gorin spoke a little bit how girentuximab is used for clear cell renal cell carcinoma, but there's also some data to suggest that this could be a radiotracer for bladder. There is some urothelial expression of CA9, and as a result, Telix Pharmaceutical now has a small trial, phase 1, looking at girentuximab zirconium-labeled 89 to look at bladder cancer. What's going to be nice about this study is there are 2 arms. One of them actually has the zirconium-labeled PET scan, and the other will be FDG PET. So it will be a head-to-head comparison looking at the sensitivity and specificity for lymph node mets, as well as, safety profile. Some of the drawbacks, again, it's antibody-based, as Dr. Gorin mentioned, so the timing to get one of these scans done is a little bit challenging. But nonetheless, the future should be interesting to see what's coming down the pipeline in terms of new radiotracers. So what do the national guidelines say? Should we be using PET or not PET in terms of bladder cancer? Well, in non-muscle invasive bladder cancer, there is really no role. Both the AUA and the EAU said there is no recommendation for routine PET imaging in non-muscle invasive bladder cancer. They said you can consider it on a case-by-case basis if you think the patients really have occult disease, either in the lymph nodes or they're already higher stage than clinically that you think there may be. NCCN has excluded PET from their guidelines. Really, they're based on CT, urography, and cystoscopy for modalities for assessment. Looking at muscle-invasive staging before treatment, the EUA does endorse getting a PET, at least conditional treatment. Specifically, they highlight when PET shows equivocal or suspicious lymph nodes. This would be the imaging of choice. As we highlighted, it changes management somewhere around 26%. AUA has not committed to endorsing it in their guidelines. There's no mandatory role for it, and it's really institutional availability and patient factors that are driving it to be offered. NCCN gives a PET, FDG PET as a Category 2B endorsement, listed as a staging modality prior to cystectomy, particularly when there's equivocal conventional imaging. Kind of a summary slide of the recommendations you can see here across organizations. The non-muscle invasive bladder cancer is not endorsed. Pretreatment muscle-invasive bladder cancer, at least by the EUA, suggests it can be used. Limited response in terms of neoadjuvant assessment. Post-cystectomy surveillance, not widely adopted. Metastatic disease, it looks like it's given the green light by a number of institutions there. So really in clinical practice, when do I order a PET scan? Typically, I order one in patients who have equivocal CT findings, whether that's indeterminate lymph nodes, bone lesions, clinical hydronephrosis. In patients who can't receive IV contrasted imaging, this is often the staging modality of choice. Patients with high-risk features on TURBT or variant histology, typically those are the patients that I'll get an FDG PET on. Neoadjuvant chemotherapy response, like I mentioned, that's a little bit outdated already in the era of EVP, but occasionally we'll get it in that setting. And then suspected recurrence and type of rising tumor markers without CT confirmation, it may be a role for that. So to wrap up, in summary, FDG PET does change the stage of patients when we get it, often up stages, probably around 26% of patients. It detects more lymph nodes than CT. In terms of guidelines, really the EUA is the ones that endorses it in terms of getting one prior to cystectomy, but there is no role definitely across the board in non-muscle invasive bladder cancer. Diuretic protocols may help to determine if there's residual disease and T staging, but this is not widely adopted. I would be in favor of using an MR and getting the VIRAD system rather than the diuretic protocol. And the future is exciting, whether that's the fibroblast activation proteins, Nectin-4, PSMA, PET, or girentuximab. We'll see what the future holds in terms of molecular imaging for bladder cancer. So with that, happy to take any questions. And like I mentioned, if you'd be so kind as to fill out the questionnaires later on when you get them in your email. But thank you for attending, and I hope you all have a good rest of your meeting. Thank you.